that's CD28, via versus T-cell and lysocell, which have a costimulatory domain or 4-1BB. Okay, and these are essentially the studies at the bottom that led to the FDA approval of these CAR T-cell therapies. Now, if you look at the studies, the original third line or greater studies that led to FDA approvals for these things, what we see is that in all the studies, we have very, very high response rates. It's about what we say is 80-60 and 60-40, meaning around ZUMA-1 and Transcend, you see approaching up to 70s, 80% for overall response. But what you see is that you have about a 54% of patients that get a complete response. And you can see that this is actually pretty similar across the group, with the exception of tisagenlecleucel, which is a little bit lower. But if you look here at the 2-year PFS and OS, you kind of get the same theme, meaning that at 2 years out, only about 40 to 50% of the times, in this case, okay, 40 to 50% of the people had already relapsed, okay, at that time, okay, meaning that only 42%, for example, on the ZUMA-1 trial, had ongoing remission at 2 years. Kind of showing us, right, that this is very exciting and novel technology, but there's still a lot that we need to do to help these patients. When we looked at the toxicity profile, I don't know if you remember that we just talked about the co-stimulatory domains, but you can see, okay, that this dramatically changes what we see in regards to toxicity with the 3 products. So for ZUMA-1 and ACCREDITED ciloleucel, we see that there's a much higher rate of CRS, but as you guys can see, it's mostly grade 1, grade 2 CRS. But the biggest difference really comes to the neurotox when you differentiate between the constructs. As you can see with the ZUMA-1 trial using ACCREDITED, okay, you have a 64% of ICANS with a 32% grade 3 or higher of ICANS, okay? So these patients could get very sick. These are all the long-term survival that we have at the last follow-up for these 3 different products. And what we're seeing is a very similar theme, that a lot of patients respond pretty quickly on, but by 6 months or later, over 60% have already relapsed, okay? If you look at the 5-year data for ZUMA-1, which we'll talk a little bit more about, we see that the 5-year overall survival is 43%, and the 5-year EFS is only 31%, meaning that 69% of the patients at 5 years had relapsed of their disease. When we compare the SCHOLAR-1 data of what relapse refractory DLBCL looks like compared to the era that we're in now, the CAR T era, as you can see, we could see that the survival has dramatically changed, right? And this is what led to a really big shift in how we manage relapse refractory DLBCL. So we all know that clinical trials, right, is where results are best. You have your young guys who are white within certain age groups, and you try to optimize the results. But what about CAR T in the real world? Does it match what we see in the clinical trials? Well, this is actually the largest study to date, and it's part of the U.S. Lymphoma CAR T-cell Consortium, and 275 patients were included in this study, okay? And what they saw is that these patients that were included in this study, when they looked at outcomes, okay, using the same products as in the pivotal trials, they saw that the efficacy was almost identical to that seen in the trials, similar with the toxicity, very similar to what was seen in the pivotal trials. But the biggest caveat from the study is that 40% of the patients that they looked at for this retrospective study would have never met eligibility criteria for ZUMA-1, meaning not only does this treatment work, okay, but it works in patients who are sicker than those that were actually in the pivotal trials that led to FDA approvals. At ASH 2023, that same consortium led their 5-year data, which looks almost identical to the data we see with ZUMA-1, right? And so from this, we gauge that the CAR T use, the outcomes and toxicities that we see on the trials are pretty similar to what we see in the real world, okay? All right, so let's talk about age in CAR T-cell therapy. This was a very, very interesting study that was presented at ASH this year, and it was about finding out, right, whether age was a major factor, okay, in regards to increased toxicity or decreased efficacy after CAR T-cell therapy. And so this was also a multi-center retrospective study, including about 209 patients. And these were patients who had received any type of commercial CAR T product, okay? And this is, and what they did is they compared efficacy and they compared toxicity to historical controls, okay? And what they saw was that efficacy was pretty much maintained okay, comparative to the pivotal trials, okay, it was maintained in the elderly population. Not only was it maintained, but they actually have different age groups that they look for differences in. And you see that there is no difference among the age groups from the age of 65 up all the way to the 80 to 90 up. There is no difference in outcomes, meaning that if it's just, meaning that elderly patients should not be excluded from CAR T just solely due to the chronologic age, whether it's morbidities and other kind of medical conditions that they have, that's a reason, but chronological age should not, because we now have data that shows that it's still effective and still shows similar toxicity profiles regardless of the age up until the ages of 80 and 90s. So as we all know, CAR T cell therapy, the indications for it have dramatically shifted in the last 3 or 4 years, right? Prior to this, it was all third line or greater. But as we know, based on 2 pivotal trials we'll talk about now, CAR T cell therapy is now indicated in the second line setting. And as we'll talk about, it's indicated in those patients who are primary refractory or who have had their disease come back within 12 months. And so this is 75% of DLBCL patients, right? And so this is going to be the majority of patients in the second line setting that are now shunted, right, towards CAR T cell therapy, as opposed to what the standard of care was 5 or 6 years ago, which was autologous stem cell transplantation. These are the 2 pivotal studies that really looked at the primary refractory population and those that relapsed within 1 year. And this was the ZUMA-7 study using axicabtagene ciloleucel. And then there was the TRANSFORM study using lisocabtagene ciloleucel. What they saw is they found survival benefits, okay, when compared to the standard of care. And more importantly, as of March of last year, we finally have confirmed that there's an overall survival benefit when using axi-cel versus standard of care in the second line setting for patients who are primary refractory or have their disease come back within 12 months. Okay, and so this has really solidified the standard of care for CAR T in the second line setting and has dramatically increased the amount of referrals that academic centers are getting for CAR T cell patients. So there's another very important study that is less talked about, but it's another important study to be aware of. And it's a study that they just read out the update in this ASH, and it's called the pilot study. This study looked at patients, okay, patients who were ineligible for transplant, okay, and had relapsed up to 1 time, meaning that this was second line setting and above. And these were in transplant ineligible patients. And so what they saw in this setting, okay, was that once again, similar to the pivotal trials that we've been looking at, the response rate is 80, around 80. The complete response rate is in the 50s. And if you look here, okay, the 18-month PFS rate is 42. So very similar, once again, to the data that we see in the pivotal trials. And so this actually led to an FDA approval in the second line setting for lisocabtagene ciloleucel in the transplant ineligible patient, okay? And what's interesting about the study as well, which they just reported at ASH, was that 53 of those patients who had achieved a complete response were an ongoing response at 18 months. Once again, confirming what we all love about CAR T, in that it is a curative modality of therapy. So I wanted to give you guys a conclusion slide in the second line setting, right? These are the patients that we are typically seeing for CAR T. So the primary refractory relapse within 12 months, and then the transplant eligible per the pilot study, which Dan, you may know, Leo Gordon is the senior author for this study here. It was at Northwestern. And so, yeah. And so the current FDA approved regimens are actually axi-cel and liso-cel in the second line setting. And of course, as I mentioned before, the overall survival benefit was confirmed with axi-cel in March of last year. So this was another kind of, this was a study that was also presented at ASH. And what it does is it's one of the first studies that really uses technology like ctDNA or circulating tumor cells and looking as a biomarker, okay, for predicting early outcomes in patients with CAR T cell therapy. And so this was a very preliminary study, but it was a proof of concept study. And what they did is essentially what they did was they quantified circulating tumor DNA at baseline. And then they quantified circulating tumor DNA 7 to 10 days after CAR T cell infusion. And what they saw almost unanimously is that the majority of all the cells dropped by tenfold compared baseline to 7 to 10 days. And that's the rate that we would expect for that drop in the ctDNA for an effective or what's predictive of a response. And so what they saw is that the patients that had the largest drop in circulating tumor DNA between baseline and the 7 to 10 day period, 100% of them, it was related, 100% had responses on PET scan, whereas those who had less than this 1.5 log full drop, only 62% had a response. And so the authors concluded that that this is the beginning of using possible ctDNA as a biomarker and a prognostic role for not only determining or trying to predict outcomes in this patient population, but also possibly to predict whether we should be changing management in the future based on clinical trial data, of course. So what we do know, though, is that after CAR T cell therapy, if you do relapse after that, the outcomes are dismal, okay? They're especially dismal in the patients who have a relapse within 30 days, okay, where the median overall survival is typically about 3 months for these patients. So once you relapse after CAR T, these are patients who do not do well, okay? One of the preserved technologies that we have that has been shown to remain effective in patients who are refractory to CAR T cell therapy is allogeneic bone marrow transplant, okay? And so what we see is that the outcomes are actually very similar to the outcomes that we see in patients who never had a history of CAR T cell therapy. So it's still retained a very effective modality of therapy. And what we see here, obviously, with other things is that if you go into complete remission to your allogeneic transplant, you're going to do better. But all this shows is that this is a good modality of therapy for patients who are relapse refractory, especially after CAR T cell therapy. Okay. All right. So now we've talked about how CARs have really changed the landscape for how we treat lymphoma. They've changed the outcomes for lymphoma. Okay, but I think it's time to talk a little bit about some newer technology as well. So I wanted to start by talking about the future of bispecific T cell antibodies in the treatment of relapse refractory large cell lymphoma. So the original one, or the BiTE, okay, was blinatumomab, and this was in the use of B-ALL, okay, in the relapse refractory setting. But more recently, and the ones that are now being used for lymphoma look more like this, an immunoglobulin-like structure, which has 2 different binding domains. And the ones that we most commonly use in large cell lymphoma is epcoritamab and glofitamab. All right, and so this is giving you guys a little bit of a summary of what these bispecifics do. They essentially recruit the T cells to bind to the tumor cells for this bridging, okay, by the bispecific antibody, okay? And both constructs that are FDA approved right now for diffuse large B-cell lymphomas are CD20, CD3 binding constructs, okay? So they bind the CD3 on the T cells and the CD20 on the B cells. So in regards to bispecific T cells that are actually FDA approved, there's 2 of them. So the first one is glofitamab, okay? Glofitamab is an IV therapy and it's time limited. You can do it up to 8 doses, okay? But you can do even longer if there's any concern about a partial response. ACCREDITED, on the other hand, is a subcutaneously delivered medication and it's a more indefinite therapy, okay? And so these are the 2 FDA approved drugs that we have available right now. Now, let's talk a little bit about ASH 2023 updates, okay? So we just talked about how glofitamab was FDA approved in the relapse refractory setting after 2 or more prior lines of therapy. And so this is all based on this pivotal phase 2 trial in which they started, okay, with glofitamab, and they actually did, as you can see in cycle 1, ramp up dosing to mitigate the risk of CRS. It was also given with obinutuzumab on day 1 to also help with the CRS, and this continued on for 21-day cycles, okay? Now, you could get up to 12 cycles, as you can see here, which is about 8.3 months of therapy, but if there was concern for partial response, you can continue to treat. What we saw that was very important from this study that was read out is that 33% of patients, okay, on this study had already received CAR T cell therapy. All right, and so these are heavily pre-treated patients, and these are even patients that have seen CAR T cell therapy in the past. And so there's very little data with any of the novel therapies that we have that really look into this subgroup population. Now, what we see here, even more importantly, right, is that the benefit that was seen by glofitamab, this bispecific antibody, where we had CR rates, right? As you guys can see here, overall response rates in the 50s with CR rates in the 40s, okay? Not too far off, okay, from what we see with the CAR T products. And not only that, but what you see as well is that you have long durations of response for the patients that actually went into complete remission, okay? And as I mentioned regarding the longevity of response is that the majority of patients who were at complete remission at the end of their treatment were actually still in remission at 18 months. Once again, really implying this definitive possible curative therapy, although more follow-up data is required to confirm this, okay? So epcoritamab is the other bispecific antibody that we have. And this was approved based on the EPCOR NHL-1 study. And essentially what they did was they used epcoritamab in a similar method, but without the obinutuzumab. And this was typically continued indefinitely, as I said, and that led to an FDA approval. So what I did is, based on the two FDA-approved bispecific constructs that we have right now, I decided to give you guys a little bit of a difference between them. As you can see, one thing that is the same, though, is that both included prior CAR T cell therapy, right? So we finally have data in patients who had, relapsed after CAR T. What we see is they were enriched for this population. What we also see is pretty good response rates, right? Overall response rate of 59 and 63, and then complete response rates of about 40%. The one thing that, personally and anecdotally to think about as well is the median time to response, okay? This is a slower acting drug. It takes a couple cycles to start seeing a response, right? And so if you have somebody who's very sick and has a large burden of disease and needs to be treated right away, okay, it's something to definitely think about. And what you guys see here is once again highlighting the durability of these responses, where 80% of the patients in 1 year, or 80 of the patients who had CR were still in CR at 1 year, similarly with the epcoritamab. Now, when you look at CRS, okay, the reported CRS in the clinical trials, the grade 3 CRS is actually pretty low comparatively to the pivotal trials for CAR T cell therapy, but it doesn't mean that it does not happen, okay? So it's important to talk about. So one other very exciting, so we've talked about the RT and how that's changed kind of the disease that we're treating. We've talked about the role now of bispecific antibodies, but now the newest thing is combining bispecific antibodies with other novel therapies. And so this was one of the exciting studies that was presented at ASH, and it's the combination of mosunetuzumab, which is a CD3, CD20 bispecific antibody, very similar to epcoritamab or glofitamab, okay, in combination with polatuzumab, which is a CD79B binding antibody drug conjugate. And the way that this was given, or the way that this trial was designed, was that you actually needed only one prior line of therapy. So meaning that patients can get this in the second line setting, right? Which is not a current FDA approved indication for bispecific antibodies. But this study does allow patients who have had at least one line of therapy. You had to be transplant ineligible if that was the case. But what they did is they started the polatuzumab with the mosunetuzumab in a similar way, right, to the step-up dosing that we saw with the prior bispecific antibodies, where we have the 1 milligram, the 2 milligram, and then the 60 milligram dosing. And then as you can see here, as you go out, you have more stable dosing per cycle. What they saw here, once again, in this very heavily pretreated population, was that there was a very good response rate. Similar, maybe a little bit higher than the other bispecifics on their own. We see that the overall response rate was about 63%. If you guys remember, it was about 50% with a bispecific alone. And the complete response rate was 51% as opposed to about 40% with the bispecific alone. Remember, these small changes in response rate are huge because the complete response patients are the ones that have durability of response and have the chance of cure. So the higher proportion of patients we can get in complete response to these therapies, the more likely and hopefully, the more likely they are to have long-term durations of response and possible cures. So so we talked about that. Okay. And so when we look at patients, once again, okay, who have had prior CAR T cell therapy, we see that this is still an effective regimen for them. Okay, now the CR rate is a little bit lower. It's at 40% versus 50% as we saw in the entire cohort. Okay, but it's still, it's still very active. And not only that, but once again, the median progression-free survival was long, and about 40% of them had extended durable responses. And so what we know as well from this is that this regimen demonstrates durable responses not only in the entire cohort of relapsed refractory DLBCL, but also in patients who specifically had CAR T-cell therapy in the past. Oh, sorry. So when looking at safety, okay, the great thing about this regimen was actually it was relatively very safe, okay? As you guys can see here, the grades or the incidence of CRS is very low. And you could see that the majority of all CRS that was seen was low grade, right? Similar to the ICANS. And I want you to compare these to the, for example, 40% ICANS grade 3 or 30% grade 3 toxicity seen with ACCREDITED, for example, right? And so this is supposed to be a much less toxic therapy. And so it's fixed duration, okay, and it induces durable responses, including those with prior CAR T. It's an outpatient therapy, okay? And they're saying that they're manageable, right? But we'll have to see when this translates to larger trials and ends up making their way to the clinic. And there is a phase 3 study that's going on right now looking at mosunetuzumab plus polatuzumab, given the encouraging phase 2 results. All right. So what data is available about sequencing these therapies, right? Because once we get to 2 or greater lines of therapy, your FDA approvals can be for either CAR T or bispecific antibodies. So we're still trying to gather data, if there is any right now. And there was some that was presented at ASH 2023 I'd want to share with you guys, all right? So this was a large retrospective study. And what they did is they looked at patients. They had 2 cohorts, okay? They looked at patients, as you can see here, that was a bispecific antibody cohort. So these are patients who essentially have gotten a bispecific in the past. And then there's the control cohort, who are patients who had never been exposed to a bispecific antibody. And then they compared outcomes after CAR T-cell therapy, okay? And what they saw, okay, is that if anything, the bispecific antibody cohort, so the patients who had received a bispecific antibody in the past, responded equally well to CAR T-cell therapy than those who had not been exposed to a bispecific in the past. Pretty much indicating, right, that these are independently effective modalities of therapy. And so prior exposure to bispecific antibody, according to the limited data available, did not impact post-CAR T survival. And not only that, but the lack of response to a prior bispecific antibody did not predict how well you would do with CAR T cell therapy. And so now once we get to this area, right, is where we have exactly what I was mentioning. You're at 2 greater lines of therapy, and you have your FDA approvals for either CAR T or bispecifics. And so these are kind of pretty slam dunk right now for CAR T cell therapy indications, right, in the second line setting. But it's really after the failure of second line where we really have to think about the data that's available for the patient that's in front of us. And so when you take this into account, there's multiple factors that we have to look at. One of the big ones for me when I look at my patients is that CAR T cell therapy has longer duration of follow-up, which means that I know through not only second line or third line trials that these are durable responses that are maintained across subgroup populations of very sick patients. Okay, and I have 5-year follow-up data that really proves to me that this is potentially curative. Now, the data looks good for bispecific therapies, but one of the limitations we have is we don't know 5 years. We have 2-year data, right, or 3-year data, but we don't know the 5-year data. And so it's hard to make those assumptions, okay. CAR T-cell therapies, typically single infusion, right? Whereas bispecifics, typically, yeah, they're off the shelf, but these are months, if not indefinite, depending on the therapy option that you choose. And so these are all kind of the factors that go into choosing, what you would do in the second or third or the second or greater line setting. So at ASH 2023, they did try to help out, okay? And so in their recommendation, okay, what they saw is that if you had 2 or greater lines of therapy, okay, because of the long-term follow-up, that really shows CAR T to be a curative modality of therapy, okay, especially if the patient is younger, the patient is able to tolerate therapy and they're CAR T eligible, their recommendations are actually to proceed with CAR T cell therapy at this time prior to a bispecific antibody. And it's mostly just based on the fact that it has follow-up data that shows that it is a definitive modality of therapy. All right, now this is very, very early on. Once again, we see all this bispecific data coming out, so this is likely to change by next year. But these are kind of where the field is going. And I think this is a pretty kind of good overview of kind of how the field is changing and the different modalities of therapy that are impacting and improving lives for these patients. And then I have my question. When should I?
The question is answered in that pre-test.
Oh, okay, great. Oh, okay, cool, guys. Sorry. I was retesting you guys. Yeah, yeah. All right, cool. So, right. So what do you guys think it is? Any takers? Brave souls. Right. So which one of the products for CAR T has an FDA approval indication in the second line setting for transplant ineligible folks? Based on what trial? Pilot. There we go. Great job, guys. Liso-cel. Okay. And so this is an open phase pilot study, which is what we discussed, looking at patients with relapse refractory large cell that essentially had that were not eligible for transplant after one line of therapy. So this is an indication in the second line setting for that guy who's relapsed after 12 years, but is not a transplant candidate. They can still proceed to CAR T through liso-cel because of the pilot study. And thank you guys so much. I know that's a lot of data, but I wanted to make sure to give you guys context as well. All right, so I'm going to give the mic back to, oh, yes, questions.
Thank you, Carlos. It was a very interesting talk. So do you find the problems that we have in multiple myeloma in terms of access to the CAR T cell therapies? And what are your thoughts when you don't have access? What would you recommend for the rest of
Yeah, so I mean,
for the audience?
we're kind of blessed in the lymphoma world, right? Where it's not nearly what we see in the myeloma world regarding slots and availability of CAR T. I think we've had wonderful representatives who've worked with us, from the companies that work with CAR T, at least in our center. There's not been a single patient who had wanted to do CAR T on that hasn't been able to do it in the manner that it's supposed to be done. The one exception that we do have is in undocumented immigrants, okay, which is a very, very large and really unfortunate problem, okay, because, Illinois, we used to have coverage for these patients, but it sounds like we've taken that back. And so that is still one of the challenges that we have.
Thank you.
Yeah.
Thanks, Carlos. That was really good discussion. Again, another myeloma person, but actually, I was interested by some of the data that you presented with prior exposure to bispecifics and the efficacy of CAR T. We actually just had this discussion not too long ago in myeloma, and we're not seeing similar observation. Actually, we're seeing decreased efficacy. Well, we're realizing that it's probably best to position CAR T first. Before bispecifics. So why do you think in the lymphoma that's the case? And then is CD19 loss, where does that play into resistance or efficacy of the therapy?
Such a good question. Yeah, absolutely. So I think a lot of it has to do with the targets, right? So with CAR T, the majority of our targets are anti-CD19. Our bispecifics are CD20, CD3. Now, I know in myeloma, you guys have a lot of anti-BCMAs, and that may, I don't know if the study looked at whether it was anti-BCMA, CAR and anti-BCMA antibody or anything like that. But the only thing I could really think about, right, apart from the fact that, I mean, we see even the toxicity profiles are very different among the bispecifics, right?
Yeah.
But I would think maybe the targets, maybe the structure themselves, I'm to be honest, yeah. That's a good question.
And then I think with the bispecifics, I mean, the model in myeloma is that you just keep treating until progression or toxicity. It's interesting that one of the drugs is indefinite and one of them is a fixed duration, but then the overall duration of response and PFS are pretty similar.
So we'll see with larger follow-up, right? So it doesn't matter that we're continuing the epcoritamab for, 2, 3 years, 4 years. What do the 5-year survival look like? What is the, to be honest, right now, it doesn't look like there's going to be a significant benefit, but we don't know. It's way too early. Yeah, that's a really good question too.
So at your institution, for patients that progress that are transplant eligible, are you favoring more towards transplant rather than go to CAR T?
Yeah, so you're talking about like after first line therapy for
Correct.
large cell lymphoma. So for me, what predominantly dictates is how long it's been since they've been treated. So if they ever got a response with chemotherapy, if it's not primary refractory and it still hasn't been, within 12 months, to me, what that says is, hey, this patient is chemo refractory if that is the case, right? And so at that point, especially based on the ZUMA-7 study, that's when I would treat with CAR T, second line CAR T with ACCREDITED or liso-cel over autologous stem cell transplant. But I have a patient who's 2 years after treatment. It's very different because to me, what that shows, or 3 years, is that they're chemosensitive, but their disease came back. So does that mean that then they would benefit from an auto, which is predominantly chemotherapy based? So essentially, I base it based on how long ago patients have been treated. So if it's greater than a year, I typically shunt patients into the transplant. In the second line setting, if it's been less than a year or they're primary refractory, meaning they've never gotten a complete response from the therapy itself, that's when I think, okay, well, chemotherapy, they're chemo refractory, more chemo in the setting of transplant is not going to do them benefit. Let's shunt over to CAR T cell therapy. But that's the big thing that's changed, right, in the last year or so.
And then another question is, at your institution, are you guys doing any lead-in approaches to improve T cell functionality?
Oh, that is so. I actually opened. It's funny you asked that. So right before leaving my training at Northwestern, I opened up a trial that did exactly that. So we used ibrutinib, which is a BTK inhibitor, in efforts of modulating the CARs. So we would prime them before the apheresis, and then we would restart the ibrutinib about 6 months after to try to maintain and change the tumor microenvironment and change and prime the T cells themselves. So it's a very interesting study and it's still, I think it's fully accrued, but it'll be interesting to see. Yeah, but there are multiple studies that are looking at that.
Last question. Do you know the median time to response for patients with POLA?
It's on my slide, I think.
Okay.
No, actually, it's not. It's not.
I missed it.
I'll be
Yeah.
honest with you. It's it's got.
Don't worry about it. We can find it.
I'd hope sooner because of the POLA, but that'd be a guess completely. So I don't pretend I didn't say that. All right. Thank you, guys.
Thank you, Carlos, for that excellent presentation. We're going to switch gears now to another disease, which is multiple myeloma. Okay, so we're also going to be talking about T cell therapy now, but in the multiple myeloma setting. This is a very fascinating topic as well. So I hope to keep you guys interested during my talk. These are my disclosures. So I will start with a case. This is a 74-year-old man with highly aggressive multiple myeloma diagnosed 10 years ago. And this patient has received standard of care treatment with a proteasome inhibitor, lenalidomide, and daratumumab. He has received the 3 most active drugs that we have in multiple myeloma, and after that, he's relapsed. Later, he received carfilzomib and pomalidomide. So this is what we call a penta-refractory disease patient. What would you recommend next to this patient? Would you continue treatment with selinexor, belantamab, and anti-BCMA, conjugate bispecific antibodies, the 3 that have been approved, or any of the 2 CAR T cells that have been approved on this setting? There's no way to respond, I think, but you can start thinking on how we are going to move on our lecture. So this is where we are going to be talking about in the triple refractory setting of patients. These are the patients who are refractory to the most active drugs that we have in multiple myeloma, a proteasome inhibitor, an IMiD, and the anti-CD38 daratumumab. This is what we used to call the pentarefractory. The pentarefractory now includes patients who had received pomalidomide and carfilzomib. So these patients, until recently, had a very poor prognosis with a median survival of less than a year, PFS less than 3 to 6 months. And here's where the bispecifics BCMA came in a few years ago, changing the paradigm of how we treat this highly aggressive patient population. And so how do we already know how these T-cell engager therapies work? They use, for the most part, the T cells present in our patient. So in the case of CAR T cells, these are genetically modified cells that recognize an antigen that's present in the myeloma cells, and when in contact with these cells, produce cell lysis and death. In the case of bispecifics, the bispecific has a receptor that recognizes a CD3 and another antigen present in the myeloma cell, leading to the same lysis and death of the cell. And so here we see what are the targets that we find in the myeloma cells that are potentially druggable, and we have taken advantage in order to kill the cells. So these are present. These are the antigens that are present in the myeloma cells. The first antigen that was found was a B cell maturation antigen that's present in the plasma cells, in mature and in the myeloma cells as well. This has a function for important signaling function in the mature B cells. The other newer antigens that are druggable, it's the G protein coupled receptor class C group D, and the FcRl5. The GPRC5D is present in addition to the plasma cells. It's present in keratinized tissues, and which we can see later explains why the side effects of this medication. GPRC5D and FcRl5, they are what they called orphan receptors. We don't know what their function is in the myeloma cells or in the plasma cells, but they are being able to target. So the first CAR T that was approved in 2021 and first BCMA CAR T cell therapy in 2021 was the ide-cel in more than 3 lines of treatment. That was a seminal KarMMa-1 trial. Patients had a median of 6 lines of therapy, and the response rate was pretty impressive in this patient population, over 73%. Median PFS was slightly lower but about 8.8%. The higher the dose, the better the response, but the more toxicities, which include a cytokine release syndrome that you have to treat with corticosteroids and eventually tocilizumab, and acute neurological toxicity that's present in about 20% of these patients. And here, as opposed to our friend Carlos Galvez, CAR T cells in myeloma are not curative. This is a treatment that is a one-time dose, but eventually all the patients are going to relapse to this treatment. Cilta-cel was a second CAR T cell that was approved by the FDA February 2022. The difference biologically from ide-cel, it's that it has it's a bivalent molecule that it can bind 2 BCMA molecules, which potentially can make it more effective and more efficient in terms of lysis of myeloma cells. But that has not been demonstrated. This trial patients had a median of 6 prior lines of therapy, and the overall response rate was pretty high with a PFS of almost 3 years. Toxicities are about the same, similar with CRS. And interestingly, these patients develop what's called delayed neurotoxicity and Parkinsonian syndrome. That do not. That's important because these patients who develop neurological toxicities do not respond to steroids or to tocilizumab. So this is more to be concerned. So in terms of efficacy, if we can say, oh, should we choose ide-cel or cilta-cel? Although the numbers look different in terms of response or PFS, we cannot say that they're effectively different. So for the most part, this is mostly results from different patient selection in the different trials. So there's no reason to choose one over the other. So that's the it looks like a positive kind of the curves look similar, but I think we need cilta-cel needs more follow-up in order to be able to say that. Yeah. But good question. So then moving to the bispecific space, we have the first one was teclistamab was the first CD3 BCMA engager approved after 4 lines of therapy in the phase 1/2 Majestic trial. Patients had a median of 5 prior lines of therapy. Almost all of them were triple class refractory, like the patient we just discussed. And in those patients, the median PFS was 11%, response rate over 60, 70%. And the overall survival for this group of patients is over 2 years has been so far. The pearl that I want you to remember is these patients develop CRS, usually during the first cycle of treatment, that they need the step-up dosing and close monitoring for 48 hours after being admitted. After that first dose, usually the CRS is resolved. And the most recently, the GPRC5D CD3 engager was approved last year in the phase 1 monumental trial. Patients had a median of 6 prior lines of therapy, 80% of the triple class refractory disease. Median PFS has not been reported, but it's similar to what we have discussed earlier. And the pearls, similar to what we discussed, talquetamab patients also develop cytokine release syndrome and need for that first dosing to be hospitalized and monitored and given steroids if they develop CRS. And most recently, we're having a plethora of new bispecific, which is very interesting how the pipeline of bispecifics that are coming down. Elranatamab was recently approved in September 2023, and more are coming, and with different abilities to be more efficient. For example, the humanized epitopes may give them a prolonged half-life, so they can be administered instead of weekly, more every 2 weeks or every 3 to 4 weeks. Also, they could be more active. Alnuctamab is also a bivalent BCMA, meaning that it can also bind to BCMA molecules, giving it potentially more effectiveness. ABV 383 from AbbVie, in addition to be a bivalent bispecific, it has a low affinity for T cells. So it can provide a healthier T cell response with fewer side effects, less CRS. But all of this, although as interesting as it is, it needs to be proven in the clinical setting. We don't know yet if biologically this could be true, but clinically we don't know. So in terms of efficacy, which one should we choose? Either the BCMA or talquetamab, when to start. So this is a summary that shows response rate for BCMA specifics are similar in terms of response rate and PFS. We can see that patients, the ones that have been developed more recently, can be administered less frequently. So that's probably going to be how we're going to administer this these treatments. The one that are more easier to administer will be the winners. And in terms of what the talquetamab was the only GPRC5D bispecific that has been approved. Response rate is similar to BCMA bispecific. Median duration of response is about similar between a year. So there's no reason to choose between a BCMA bispecific or a GPRC5D. Although in the monumental trial, there were patients who had received teclistamab before, which make you think, okay, we can give teclistamab before and then switch to talquetamab, but the numbers are still low to say that they can be sequenced if a patient relapses. So that needs to be developed more and studied more. The number of patients are still very low. So in summary, go with the bispecific that you have and that you have available. So, and now we want to choose which one do we start first, either with a CAR T cell or a bispecific? That's a good question that we always get asked. So in terms of efficacy, I showed you the numbers. There's no comparative trials between bispecifics and CAR Ts. Some myeloma physicians believe that due to the high response rates that we saw with bispecifics, with CAR Ts, they are more specific. So most myeloma doctors would recommend starting with a CAR T cell, but there's no comparative trials. So usually sometimes we get to decide with the toxicity profile, and with the patient that we have in front of us. So, and look at their toxicity. So how about looking at toxicities? What happens? In terms of CRS, clearly with CAR T cell therapies, these patients develop CRS higher incidence compared to teclistamab and the bispecifics. And neurological toxicities as well, they're also more frequent with the cellular therapies. And importantly, there's this issue of the delayed neurotoxicity that we're talking about, Parkinsonian syndromes, and these patients do not respond to tocilizumab, steroids. The treatment is mainly supportive. So that's something to consider. So the bispecifics don't have that issues. So it's in terms of ICANS and CRS and the neurological issues. So for the most part, myeloma physicians have been using CAR Ts for a more younger population that are more fit, and bispecifics with patients that are more frail. But each of these has its own toxicity as well. Bispecifics are not innocuous. They have more infections definitely than CAR T cells due to the mechanism of action. Patients develop hypogammaglobulinemia that you need to be measuring serially. And the most frequent infections are viral infections with BCMA bispecifics. And that's why you need to be checking. The guidelines that recommend checking for IVIG levels and replace them when IgG levels go below 400, and administering prophylactic antibiotics for all these opportunistic infections. So it is something to consider, and vaccinations for patients who receive CAR T cell therapies as well. In addition to infections, GPRC5D bispecifics, they develop what's called an on target of tumor and toxicity, mostly related because GPRC5D is present in the oral mucosa, so they can cause skin rash, nail toxicity, dysgeusia, and weight loss. It's developed 50 to 60% of the patients who who receive this treatment. Management includes the use of topical creams and topical steroids. Patients might need eventually systemic steroids, there's no real good management of dysgeusia and weight loss. So this is something that needs to be addressed, and it's definitely studied. So just to summary, as Carlos did, between differences between CAR Ts and bispecifics. For CAR T, we need to be in a highly complex facility where patients can be monitored and for at least a month initially to make sure that they don't develop the toxicities that are most concerning. Bispecifics, other than the initial CRS, their patients do well after that. The incidence of CRS is higher for, and ICANS is higher for CAR Ts. Access is way more limited, as we were discussing, for CAR T cell treatment. And turnaround time, it's longer for CAR Ts. Remember that these are genetically modified treatments that can take up to 8 weeks to come back to your patient before the patient can receive it. Bispecifics do not have that issue. In terms of response rate, you can consider that it's higher for CAR T cells, but again, there's no comparison and head-to-head comparison. And for cost, for now, we could say that CAR Ts are more expensive, but we need to cost-effective analysis need to be addressed and performed. So this is, in fact, we had a debate last week trying to address all these issues and which patients we're going to give which drug, but these are the things we need to consider: efficacy, access. At our center, we still do not have ide-cel or cilta-cel. We hope that our friends here will help us with this. How about activities in subgroups? Older, frailer patients, we would definitely recommend for them to receive bispecific. For a rapidly proliferative disease, unfortunately, none of these drugs are very effective. There's new treatments that need to be used there. The safety we discussed, and also how the ease of administration of these drugs needs to be considered. It's different to give a one and done drug, as CAR Ts are, as opposed to a continuous indefinite treatment that bispecifics. And that's a discussion that you need to have with your patient, and in terms to come up with a proper plan that the patient is agreeable to. So now with what did we learn from ASH last year? Basically, with real world data, we were able to learn more how to use these medications in special populations. This is an abstract that try to study the use of teclistamab in patients, real world analysis of patients older than 70 years old. This was a study from 5 US centers, and what they did here, they compared the outcome retrospectively between patients who were young and who were older than 70 years, and see which one had worse toxicity and survival. The median age of the elderly group was 75 years old. Many of them had a poor performance status. And in summary, long story short, the patients had a similar progression-free survival to what has been developed reported in the literature. There's no signal here that older patients will have a worse survival. And in terms of toxicity, maybe the study could be underpowered, but there were no signals that there were more infections in this elderly population, supporting the use of bispecifics in elderly patients. How about what happens on the other side with the cellular therapies? ide-cel, this is a large CIBMTR study that analyzed 600 patients who had received ide-cel for relapsed refractory myeloma, and the patient population was younger, was 65 years old. responses were similar to what has been reported in the literature. And they're similar for toxicities and infections. So, but the point of what I wanted to show you guys here is that this is the number: 65 years old patients with CAR T cells that are younger are being offered this treatment in the real world data. More about toxicity in terms of what we saw at ASH. With this abstract, I'm trying to show you which patients get more infections. Do anti-BCMA bispecifics or talquetamab get more infections? So this is a French retrospective analysis. And most of the patients here received teclistamab, 200 patients. There was a small number of patients that received talquetamab, but clearly the patients who received talquetamab had less incidence of infections compared to patients who received teclistamab. So there's a signal that the hypoglobulinemia is probably playing a role there. And it is in these patients that we need to beware of administering IVIG and prophylactic antibiotics and antifungals, etc. How about toxicities on the other with talquetamab, the skin toxicity, dysgeusia, weight loss? So in an attempt to reduce these toxicities in these patients, this abstract, the follow-up which is a follow-up from Monumental 1 trial, what they did, they tried to reduce the toxicity by reducing the dosing of the patients who received talquetamab. So it was a prospective analysis in patients who had had a partial response, which occurred at the three months of treatment. They reduced the dose from every 2 weeks to every 4 weeks, or if they reduced the dose from every 2 weeks, 0.8 mg per kg to 0.4 mg per kg. And both groups with reduced dosing of talquetamab had a significant improvement on the skin rash, oral toxicity, nail toxicity. The weight loss was not as important. So that is something that these patients develop, weight loss, and we need to be aware of that and consult nutrition, because this is something that needs to be addressed with the use of this drug, talquetamab. Now switching gears, how to use, as we were discussing, usually we start giving these drugs in later lines of treatment. We see how they respond, and we start moving these treatments earlier in a hope of getting a better response. So this is what has been done, introducing CAR T cells in earlier lines of treatment. There have been 2 trials that studied this. The KarMMa-3 trial with ide-cel in patients who had received at least 2 lines of treatment. These patients could have been triple class refractory, but not necessarily. At least they had received daratumumab, but not refractory to daratumumab. It's what we call triple class exposed, the patient who received dara RVD, for example. And the other trial was the CARTITUDE-4 that allowed patients to have 1 to 3 lines of treatment, that they needed to be at least lenalidomide refractory. So they randomized patients to the cellular therapy and different regimens, most of them including daratumumab. And what we see here, the primary outcome is always PFS in the myeloma trials. So as we can see here with the KarMMa-3 trial, the median PFS was 13.3 versus 14.4. This was a little disappointing. We would expect larger benefit in PFS. The authors mentioned that this could have been related. There was a large population of daratumumab refractory patients in this group. We don't know yet. In terms of cilta-cel, appears that the median PFS was larger, but again, this trial used less lines of therapy, so it's not comparable to the other one. But we need more follow-up in terms of cilta-cel, what to say about that. So at ASH this year, we had an update, very long-awaited update from the KarMMa-3 that has 3 years of follow-up of this trial. And what they showed here, they showed the PFS that had not changed after 3 years of follow-up. PFS was still 13 versus 4 months for the standard of care patients, but they try to analyze the overall survival analysis. And although this study was not powered to analyze an overall survival, but there was a problem in this trial allowed crossover for patients who had received the standard of care, and after progression, the patients could receive ide-cel. So they did a sensitive analysis trying to exclude those patients that had received ide-cel after progressing from standard of care. And when they did that analysis, sensitive analysis, they see that there is an overall survival benefit of 41 months versus 23 months, which is encouraging. But this is still, it's exploratory. It's not although they say it's pre-specified, but it's not something, this was not the main outcome of the trial. And similarly, they did another analysis in the actually treated population, not the intended to treat population. Many patients in the ide-cel space do not actually get the CAR T cells because, as you know, they progress. They before even being able to receive the CAR T cells. So that was about 10% of the patients. So, but when they excluded the patients and included only the patients who had received initially ide-cel, they also see a trend in benefit in median overall survival. So based on this data, BMS has recently submitted the application to the FDA to have the ide-cel to be administered in early lines of treatment. So stay tuned, because we want to know what happens. One problem is going to be are there going to be enough slots for all these patients if it's approved as a, so that's going to be interesting to know. How about cilta-cel? Are we going to have it soon as early line of treatment? They didn't show a follow-up of the CARTITUDE-4 analysis. What we see here is a follow-up of the CARTITUDE-2, which also allowed one to receive cilta-cel after 1 to 3 prior lines of therapy. It had a similar design, but it wasn't randomized. And in this group of patients, cilta-cel still has a very impressive PFS with a 24-month PFS of 75% and response rates over 95%. But this study still needs a more follow-up and more data in order to say whether cilta-cel can be incorporated as an early line of treatment, but we're hoping it does. And finally, the last abstract that I wanted to share with you was the first GPRC5D CAR T cell treatment that was shown on this year or last year by Susan Bal from UAB. And the response rates for this CAR T they're very impressive, also around 100%. And this included patients who had received BCMA therapy before. So these numbers are interesting. This is still, although very preliminary, and but it's very encouraging that we have new treatments for this patient population. So take home points. These are bispecifics on CAR T-cell therapy are an important breakthrough after more than 3 lines of therapy. Real world data we have teaches us how to use them better. And CAR T-cell therapy is very effective, and we're waiting on the FDA approval in early lines and see what happens. And future studies will determine how to best sequence these therapies. So there. Questions?
Anybody?
I have a question about IVIG, and I think this will be applicable to not just the myeloma folks, but ALL, lymphoma, people who are giving the BSABs. So obviously we learned from bone marrow transplant that the role of IVIG is really like there's the choosing wisely guidelines that now tell us that there's really no data to support giving it. What are your thoughts on giving IVIG in this setting? You think it's more to treat ourselves, or is there, you know, strong supporting evidence to show that it actually prevents infection, morbidity, mortality from infection?
Yeah, so all these trials were per the physician's discretion to give them IVIG. I think, and I know there are retrospective analysis of patients who received bispecifics and BCMA bispecifics, and they've seen a reduced rate of infections in patients who had received IVIG. I would definitely save them at least for patients who receive teclistamab or elranatamab for sure, and see on the GPRC5D whether they cannot be on it. But that's my opinion. Maybe this will change.
Get to it. Based on the 2 FDA-approved bispecifics that you were talking about, right, for multiple myeloma, how do you, or excuse me, I know there's 3. So, but based on the anti-BCMA versus the G5, yes, that one. How do you, like, if you have a patient who could get either, right? You have one where it's more skin toxicity, but on the other, it sounds like you have higher risk of infections. Is that something you just discuss with your patient and you kind of talk about what's best for them, or do you have a go-to? Or you know, what, I know there's not much data, but.
Yeah, so considering the response rates are similar, they have different toxicity profile, but there's more data giving teclistamab and patients being able to receive teclistamab after that. So I think I would do teclistamab and then teclistamab. That's I think until we get more information. That's how
Thank you.
I would approach it. But yeah, the industry is going to say, no, ours is better. No.
Data.
Thank you, guys.
I got stuck in a validation.
Oh, you're so young. Got it.
Okay. So welcome back, everybody. We have 2 more presenters today. First is going to come Dr. Sean Quigley. He's our ALL specialist, well, AML as well, but he's going to talk about the new developments on acute lymphoblastic leukemia. So please give a nice welcome. Thank you.
Thank you. Hi. So, wow. I've actually been at UIC 20 years next October. Which is weird because means I must have started when I was like 5 or something. But anyway, so we're going to talk about acute lymphoblastic leukemia. and the ASH abstracts. So basically there's about 500, so we really should get moving with this talk. And so these are disclosures. I'm on the speaker bureau for Servier, and I'm doing investigator-initiated trials with Pfizer, AbbVie, and Teva, and Beijing, apparently. Okay, so as I said, I've been at UIC for about 20 years. We actually got onto the pediatric bandwagon in terms of regimens for AYAs and older patients quite early. So we've been doing that since at least 2010. So the point of this slide is just what I've seen in this slide and the next slide is what I've seen happen in ALL over the last 20 years. And so by increased up and wider out, I meant that we are seeing across both an upregulation, how is one way of saying it, in terms of these treatments. For example, pediatric regimens and AYAs, we're now spreading them out to older adults. And by wider, I mean that, this all started in the academic centers, but now, for example, we take blinatumomab, inotuzumab, these are now being spread out into the community. And for example, I know that Amgen at one point had a big educational thing to try talk about MRD in ALL specifically for the community. So anyway, so these, as you can see here, are some of the things, the trends that I've seen. We, as you know, so the pediatric regimens, that whole work started around 2004, actually, where the initial trials, the initial studies looking at how pediatric regimens were doing so much better in these AYAs, and patients who got the adult regimens did much worse. MRD, I'm sure it's been addressed here today, but now this has been going on again, primarily started in Europe, use of MRD to direct therapy in ALL. The PH classification came out about 9 years ago, initially done at St. Jude, and is, as we'll talk about, identifies those at high risk of relapse. You've already heard of, I'm sure, the bispecific T-cell engagers. Blinatumomab was the first, and actually the initial study is the first in human study, and that was done in 2001. So we have some experience with these things. But the point of for 4 and 5 and 6 is that we are now, these all came out in relapsed ALL and be now moved into frontline. So I've only 20 slides, but it looks like it's going to take about 2 hours. For those of us who are not in a specific part of Texas, we use pediatric regimens rather than hyper-CVAD. And for pH-positive ALL, as I'm sure you know, there's really been a push for use of blinatumomab and TKIs for this type of ALL. Nelarabine is now being used particularly for relapsed, initially in relapsed ALL, T-cell ALL, and now in frontline therapy, which I'm not going to discuss. And number 9 was work that's come from University of Chicago. Wendy Stock's group has looked at venetoclax and navitoclax as pro-apoptotics in combination with chemotherapy in relapsed refractory ALL. I'll briefly talk about the exciting news on menin inhibitors, even more briefly talk about CAR-T. And I just wanted to mention number 12, which I think is an important thing for us as carers for these patients, that multidisciplinary teams are required. This is like ICU care in a way, and it will not function, and sometimes it doesn't function even with this group, but you need all of these people: pharmacy, nursing, coordinators, navigators, social workers, PT, dietitians, etc. Okay, so again, I realize it's the end of the evening. You've previously had some of these discussions, but just to talk briefly about blinatumomab, as you know, it's a bispecific T-cell engager, and see, where does this work? Yeah. So I describe it as sort of a fusion of the business end of immunoglobulins. So you have an anti-CD3 and an anti-CD19. So as I said, the first in-human study was done in 2001, but in 1995, there was a PNAS paper talking about these bispecific T-cell engagers for studies. So these basically, the CD19 basically lands on anything but expressing CD19, including normal lymphocytes. And then T cells are moseying along and sort of bump into the CD3 target. And you get an immunological synapse, you get perforins, granzymes, destruction of your target, which is hopefully a leukemia, B-cell leukemia cell rather than a lymphocyte. And then the T cell hops off again and does more. The other thing is it releases a bunch of cytokines, depending on, and obviously those will increase depending on the number of targets, giving you your cytokine release syndrome. On the left side, I just wanted to briefly mention about other things that people have thought about to try improve the efficacy of BLIN and other bispecific T-cell engagers, which are now, as we were talking about, myeloma, is now being used in both solid and liquid tumors, including colon and lung cancer. So this paper described using checkpoint inhibitors to try improve the signal, using a co-stimulator, using a bispecific that actually binds CD28. And there's other mechanisms, and obviously, as you know, with chemotherapy, to try improve the function of blinatumomab. So sorry, guys, we're going to have a number of these busy slides. So I just wanted to, there are 80 abstracts on blinatumomab at ASH, and these are, so I sort of just moved them into sort of themes. So I don't know if you, oh yeah. So I just wanted to mention that I'm going to talk about abstracts. If you do this, blood 2022 142 supplement 1, and put in the number, you will get directly to that abstract eventually. It does work. I've tried it many times. Okay, so for blinatumomab, as I said, we started off in relapsed AYAs, older adults, frontline therapy, and now the latest thing is to expand into pediatrics. And I think there was a paper recently looking at treatment in New England Journal, looking at treatment of infants. And so they had figured out a dose for this for children. This was just a large study, pediatric European study looking at specifically at 572 patients and comparing 2 cycles of blinatumomab versus 2 cycles of chemotherapy. Now, I'm not going to talk about the outcomes. The outcomes were as good, if not better. But the point was that the toxicity was about 50% of that seen with the 2 cycles of chemotherapy. 6% of the patients got seizures. These are grade 2, 3. And this was a very positive study indicating that blinatumomab is very safe in pediatric groups. So number 2 is an interesting thing that I thought. So there's been previous studies looked at use of blin post-transplant to see if it was any benefit, and they didn't see a benefit. So this group, what they did was they said you had to be between 2 and 6 months out, and you had to be off all immunosuppression. And then they found that they had very good 3-year relapse-free survival in these patients who were MRD negative, by the way, with getting their blinatumomab. But the point is they didn't see very much toxicity, and they saw some good outcomes suggesting that blinatumomab will work, which makes sense that they're off immunosuppression before you give a T-cell engager. It's a small study, and further work is ongoing. There's a couple of abstracts trying to figure out how do you predict which patients are going to respond to blinatumomab versus who's not. To summarize a bunch of studies, if you have an IKZF1 deletion or you've got PH-like disease, you have a much better chance of responding to blinatumomab than if you've got a KM2A disease where commonly these patients switch lineage, or you have a TCF3 rearrangement or a specific PAX5 mutation. So these patients will do better. You know from these studies that these are large studies that these patients are going to do better upfront with Blin. Then people have also sort of done some immune studies trying to figure out, is there a particular immunological pattern that would predict how patients are going to do? Obviously, most of these patients are going to have naive T cells pre-treatment because they've been getting chemotherapy. They don't have activated T cells. But with use of blinatumomab, the patients who respond, you get activation of CD8 immune cell subsets, which again is not rocket science. You'd expect this. But the patients who are going to respond will have large numbers of these activated CD8 cells, as opposed to those who do not respond. And they also get an increase in the myeloid, a change in the myeloid lineage, and an increase in Tregs as well. So as we mentioned on the previous slide, so people have looked at use of checkpoint inhibitors. And so this is a small study where people looked, I think there was about 10 patients in this study. This is from Boston. And they had a very good response to treatment using checkpoint inhibitors. They're actually using 2 checkpoint inhibitors combined with blinatumomab, 5 cycles of blin, and nivo and ipi. And they did not see very many side effects, and they are going to expand the study. Then lastly, there was a group have looked, this is a German group, a GMAL study, very small study, 7 patients, and questionable sort of responses, but are combining it with venetoclax. Okay, inotuzumab. So I have some experience with this, with these antibody drug conjugates. I've done a study with gemtuzumab and combining it with venetoclax to try to stimulate apoptosis. And so this is not a novel thought of mine. And other groups have looked at using inotuzumab in combination with BCL2. This shows you how the drug works, goes into the lysosome, changes pH, breaks the linker, the toxin goes into the nucleus, causes DNA damage, and stimulates apoptosis. And these are the forms of resistance. There's been a number of different recognition of a number of different mechanisms to become resistant to inotuzumab. So again, this is from an area in the south of the country where they basically have used hyper-CVAD or mini hyper-CVAD in combination first with blin, and then they've added in inotuzumab. The inotuzumab is used, I think, in cycle 3 and cycle 4. They were using it late after the hyper-CVAD had finished, and now they're using it early. I just wanted to talk about this study because basically, if you look at these patients with hypodiploidy, hypoploidy, near-triploidy, KMT2A rearranged, etc., these are patients who have what we call high-risk ALL disease. And what this study is showing is that when you combine hyperzivad with blin and with inotuzumab, that you are getting a 100% CR rate, 55% MRD rate after one cycle, and that these patients, it's, obviously it's a 3-year survival, but these patients are doing very well with this combination in a high-risk group. And these are just some questions about inotuzumab. Does it impact T cell collection or efficacy? And it does not. This was where MD Anderson looked at 75, they had hundreds of patients that they've treated either with gemtuzumab or inotuzumab, and they recognized they had an instance of 75 patients that they could look at. And they, looking at risk factors for VOD, they said patients, they could divide it up into 2 groups, patients who are less than 25, patients over 25. The patients who are less than 25 actually had an increased instance of VOD, and that is most likely because these were AML patients who've gotten multiple rounds of chemotherapy, including gemtuzumab. The older patients actually had less instance of VOD, probably because more of those were ALL patients, but they did see that length of therapy in both groups was important, i.e. what other drugs, hepatotoxic drugs you've been exposed to. And in the older patients, if they had evidence of liver disease beforehand, they tended to do worse. So as I mentioned, there's been efforts to try improve the efficacy of inotuzumab. One is with venetoclax. This is a very small study, but they're seeing very, very good results. 7 out of the 8 patients who were treated with this combination became MRD negative. These patients got standard dosing of inotuzumab and venetoclax. In the first cohort got 200, and the second cohort got 400, and there was no increase in cytopenias or toxicity. And so they're going to expand this study using venetoclax 400. So in the first cycle, it's given for 28 days. It's actually basically continuous venetoclax with inotuzumab. There's an interesting study looking at PARP inhibitors to prevent DNA repair. As we mentioned, you get double-stranded breaks. And they actually did some gene expression studies to try to figure out patients who, cells that were resistant to inotuzumab, and could show that P-glycoprotein upregulation was common in cells that became resistant to inotuzumab. And these are other mechanisms of resistance which are already known. Okay. Sorry, guys, we're missing a slide here. Anyway, we will move on. So it was just basically an introduction to talk about MRD. As you know, minimal residual disease is measured by a number of different mechanisms. There's flow, which usually has a sensitivity of about 0.01%. We have the PCR-based immunoglobulin T cell receptor system for monitoring that was popular in Europe before. We've gone to NGS systems now for looking for clones or clonality assays, and their sensitivity is 10 to the -6, maybe 10 to -7 on a good day. So this study is actually from China, but what I liked about it was they looked at a large group of patients, 2-3/4 of these are B cell, and they looked at the end of induction which patients were in remission and who were not. And you could see that the early T cell phenotype and the pH like patients did poorly in terms of end of induction MRD. So then what they did was they looked at these patients over 5 years. Can I say that none of these patients that they described got blinatumomab or inotuzumab? This was a COG trial, but they do have long follow-up. And the thing I wanted to point out here was that, so they categorized patients as having, as we said, flow negative, 0.01%, less than 0.01% versus the others. And basically, so these are patients who have over 1% blast at the end of induction. And you can see, not surprisingly, that these patients do not do well. But what was also interesting was that any patients who had any MRD at all, that actually it didn't really matter how much the depth of your remission was. If it was above a certain point, that you're gonna relapse. So you really need a deep remission for these patients. This also, again, sort of thing that I found this interesting, was that this was looking at, again, this is a study from China, again, with a lot of patients. And again, what they did here was they looked at patients who were MRD negative for a year. Now, MRD negative, again, is 0.01%. And so what they were showing was that, so the patients who got transplant, sorry, the presentation doesn't look great here. But the patients these are patients who didn't get transplant. These are the transplanted patients. And these are patients whose MRD was rising over a year. So what this study is showing, as I said, it's a long, out to 100 months, that the patients who were negative, MRD negative for 1 year, looks like they do not need transplant. It's not of benefit to these patients. This is a question that comes up all the time about whether flow is actually better than molecular studies to determine it, because obviously NGS is much more sensitive. So this paper was recently published in Blood Advances. I think this is Muffley's group. So basically what they did was they looked at patients who went on for transplant, so they knew their outcome, retrospective study, and tried to figure out whether, if they were MRD positive beforehand, on what level they were at, whether it impacted their outcomes. And so, as you can see here, any degree of MRD positivity before transplant actually works out to impact your overall survival. Even patients who were negative by flow but still had disease by NGS did somewhat poorly. And as you know, the E1910 study showed that even patients who are MRD negative, that they had improved outcome with the use of blinatumomab. And the other thing I want to mention here was that post-transplant monitoring was also very important. Sorry. So just briefly to talk about pH-like disease. Again, I'm sure I'm preaching to the choir here, but it's about 25% of AYA patients. And it's actually is seen in Hispanic patients, it's increased incidence, and it also increased incidence in older patients who are Hispanic. These, as you know, are the common genetic abnormalities that we see. These are mechanisms for determining whether a patient is pH-like or not. And then this is to show what we knew. These are studies looking at overall survival for these pH-like patients with hyper-CVAD versus non-pH-like patients. So you can see that it's 23% versus 60%. and looking at event-free survival, even with PEAS regimens, that it's still poorer. So what I think most ALL physicians would recommend that if patients are, that transplant is a viable option for these patients, and particularly if they're MRD positive. And sorry, I just mentioned this study here looking at BLIN, and as you mentioned before, PH-like patients seem to be particularly sensitive to use of blinatumomab, and there was a odds ratio was 5.3 that patients would respond to blinatumomab versus other types of treatment. And I mentioned at the end to await results of E1910 because these patients were not automatically transplanted in E1910. And so if we get some, this is a big study, multi-center, many patients. And so hopefully this will give us some information about patients who are MRD negative, who are PH-like, and whether they need to be transplanted. And this was just some work that groups are doing to try improve the outcomes. As you know, people are using TKIs. This was a terrible study, actually, from Italy that didn't really say anything about who got what and who got the other. So you couldn't really tell anything from this study. This was a nice study from, I think this is from Luskin, Dr. Luskin at Harvard, looking to give venetoclax 14 days in induction and consolidation. Actually, yeah, sorry, I'm not sure where this study is from. But the bottom line is that 4 days, only 7 of these 14 patients had PH-like disease. You got a complete remission in 14 of them. 11 were negative after induction, and all became negative after consolidation. And 7 out of the 11, they could not detect any minimal residual disease by NGS. And again, prelim information, prelim studies, but showing that it seems to be helpful. And then I just wanted to mention this study here. This was a multi-center trial. MD Anderson contributed a lot of patients, City of Hope, and some other, a third group. But they looked at 683 patients that were transplanted and dissected it to look at patients who are pH negative versus pH-like. What they could show is that if the patients are MRD negative beforehand, that they're going to do as well as the pH negative patients. Yes. Again, I'm sure you've heard about 3 different groups have looked at the benefit of tyrosine kinase inhibitors in combination with blinatumomab for treatment of both of newly diagnosed and relapsed PH-ALL. And we have some of those long-term results. I'll show you them. This was actually Dr. Avani's study, a SWOG study. And she has looked back at, they had only 24 patients. These were all newly diagnosed PH-ALL. And they basically set up, I didn't realize this, the regimen that Foa et al. Used, which was steroids and TKI for the first 2 to 3 months before giving blinatumomab for 3 to 5 cycles. And so this is their outcome with these patients. They looked at 6.5 years. They had 8 out of the 24 relapsed. And the rest of the patients have done very well. So Foa's regimen, I'm sure you saw in New England Journal of Medicine, looking at, as I said, based on the prior study, looking at dasatinib and steroids for about a month, dasatinib out to day 85, and then going on to get blinatumomab. So in the interim, this year, or sorry, last year, at the start of last year, Dr. Jabour's study from MD Anderson looked at using ponatinib and blinatumomab upfront for these patients instead of waiting. And so Dr. Foa's group in Italy has sort of hopped onto this bandwagon and thought, well, this looks like a good idea. So they're not using dasatinib now, they're using ponatinib. They're not waiting till day 85, they're starting at day 70. as I said, the MD Anderson group starts in the first week usually after a little bit of steroids beforehand. The other thing was they saw that 4 out of the 9 patients that relapsed, I'll show you in the next slide, actually relapsed in CNS. So they've increased the prophylaxis from 12 to 15. And they also recognized that these patients who are MRD positive and patients who have this signature are going to do badly, and so they go for transplant. So this is some of the long-term studies using TKI and BLIN in pH-positive patients. So this was Foa's original study, and so she's now, her group is now looking at 53 months median follow-up. They have 14% relapses, and the 4.5-year overall survival and disease-free survival remain very, very high. They're not as high as this study, obviously, which is the MD Anderson study, but this follow-up is much less. All right. So Dr. Birch is going to talk about his favorite thing, menin inhibitors, but I thought I'd try steal his thunder for a second. And so this is a big thing at ASH this year, was the use of these menin inhibitors for what is generally a deadly disease, particularly in infants and children with ALL. So basically, with this rearrangement of this lysine methyltransferase, previously known as MLL, you get an aberrant expression of Hox genes and a cofactor called MICE1, and that leads to a differentiation block, and you end up undergoing these cells undergoing leukemic transformation. I don't have a picture of the MLL or KMT2A protein, but let me tell you, it's 4,000 amino acids, but there's a menin domain at the N-terminus, which is key and is always present in these different fusion proteins. And there's about 90 different fusion proteins have been recognized that fuse with MLL to cause leukemic transformation. The other reason that people are interested in this particular protein is because it appears MLL overactivity appears to be important in NPM1 mutant AML, which is 30% of AML. And so as Hox overexpression appears to be key in this disease and appears to be related to KMT2A, if you have a menin inhibitor, that may help. So just to show you briefly, menin binds to the N-terminus and urine. These different inhibitors that are in development all block the interaction of menin and MLL1. And they also impact, because MLL1 is upregulating HOXA-B and the MICE gene, which is a cofactor for the Hox genes, then your menin inhibitor preventing all of this happening can have an effect both on potentially actually on FLT3 positive patients and NPM1 positive patients and the KMT2A rearranged ALLs. Do we have another one? Yep, I think so. No, I hadn't finished. Sorry. So just to mention to you, you can see where menin is here, where the MI503, which is one of the first menin inhibitors, is interacting to prevent menin interacting with MLL1. So MLL1 is unable to methyltransferase the H3K4. Okay, so just wanted to mention that in the initial study that was shown came out in Nature last year, there was a accompanying paper showing that resistance occurred in about up to 30% of these patients, and that it's mostly due to mutations of menin itself, which is preventing the drug to bind to menin. I just wanted to mention that Down here, we're trying to show that these are blasts and that you're getting differentiation of these cells with this treatment. And by blocking HOX expression, you allow myeloid differentiation to occur. And so, as is seen with other of these drugs, ATRA, ATO and IDH inhibitors, you can get interactions with CYP3A4, you can get QTC prolongation, and you can get differentiation syndrome. And these are important things to know about because they impact clinical care. Okay, and just briefly, the most mature data is for use of impronounceable revumenib. Sorry, I probably got that wrong. But so this is a sort of complex study, and I really, I guess, don't have a lot of time to go into it. But I bring your attention to the high CRC rate in these patients. So CRC is a complete remission with cytogenetic. So the point I'm trying to make is that because of differentiation syndrome, you can have patients who appear to be in remission, but if you look at their cytogenetics, they still have the KMT2A rearrangement. And the reason they have that is because these are differentiated cells, which are going to die and is not necessarily of consequence. But it's important to know about. So these were, again, without going into it, these are very refractory patients, had multiple lines of therapy. You bring in a pill, you give it to them, and you see that approximately 40 to 50% of these patients are doing very well. So as I mentioned, this became very popular at ASH, and there's 4 different other menin inhibitors in trial. And abstract number 28 was interesting. They looked at use of HMA-VEN and combining that with the impronounceable menin inhibitor, and seems to have very, very efficacious effects. Again, a very small study. Okay, just briefly to talk about CAR-T, and what I found interesting about CAR-T was what's called a Felix. So this is a UK group, came up actually in Great Ormond Street in London. They came up with this new system, which I think Matthias referred to, this low affinity use of low affinity binding to CD19 CAR T cells. And the point being that these low affinities allow the T cells not to get too activated. They have an increase in BCL2, an increase in less interleukin 27 expression. And so these T cells do not die with the same frequency that you see with the prior commercial system of CAR-T. The other thing that has come up is to use a membrane proximal epitope to try overcome loss of epitopes due to mutations, etc. So these are 2 different new versions of CAR-T. So the Felix trial, which, as I said, was actually they're using the same epitope. Maybe I'm supposed to do this. Yes, they're using the same. Their epitope is in the area of FMC 63, but it's a low affinity. Sorry. And so what this Felix study has done, it's the most mature data looking at this particular CAR-T system. They have, as you see here, they have outcome for up to 3 years. The point of this study was to show that patients who had a lot of disease, as in this lower group, over 75% blast before CAR-T, do poorly, and patients who have less than 5% blast pre-CAR-T will do very, very well. The reason that I wanted to mention this study was really related to the cytokine release syndrome and ICANS. And actually, the patients who were less than 5% had neither of these side effects. But the ICANS incidence is actually very low compared to previously. There were some studies on the previously commercially available CAR T where the ICANS rate was 50% or so. So 7% is really amazing. So I had a question for you guys. I'm not sure it's supposed to be at the end or whatever. Well, we just presented this 5 minutes ago, so as long as you were not asleep, you probably have figured out the answer to this. And anybody who's really awake will notice that this is not the slides. This is that question C is the same as question D. But anyway, so am I supposed to tell them the answer? Yeah. Oh, okay. So the answer is E, as I mentioned about that because of differentiation, that they still have cytogenetic changes, but these cells are going to die, and that you should not be concerned. Okay. So we survived as a group, I guess. So a summary of a ton of information that I presented. So one thing I was thinking was that there was no huge breakthrough this year at ASH in terms of ALL. There was a lot of things that look very promising. The menin inhibitors look very promising in what's a devastating disease for infants with ALL. But there was basically we're waiting for still E19 to result. We would like to know the results of this combination of blinatumomab and inotuzumab to reduce the use of chemo in frontline therapy for ALL. And that's this alliance study. We're waiting for that to come out. The other things that I learned was that mini hyper-CVAD with Blin and INO is actually a valid and very reasonable option particularly for older patients with ALL. MRD is important, as we knew already, to direct therapy, and 0.01%, which is flow sensitivity, may be sufficient, but you are taking a risk. Hazard ratio was 3.56 for patients for transplant who are MRD negative by flow, but actually do have some residual disease. And then the last thing was that we talked about the BiTE and TKI. You've seen some of these long-term results, and they do look very favorable to me. And the menin inhibitors, they're also being studied myeloma, CLL, and some solid tumors, and will obviously really come to the fore in NPM1 mutated AML. And then lastly, I mentioned about the CAR T, that the new products appear to greatly reduce the risk of ICANS, but the efficacy versus the available commercial products is not known at this point. That's it. Thank you.
Yeah, thank you, Sean, for that talk. So looking at the data with MRD and blinatumomab, what would be your choice regarding patients who got MRD with standard risk ALL, who got MRD with blinatumomab?
MRD negative.
Negative, yes. Would you send them for transplant?
The pH-like, you mean?
No, not the pH-like, just the regular standard patient without high-risk cytogenetics and
so we're not. And actually, I have a number of patients who are on E1910, where they got Blin as part of chemotherapy, and including patients who are high risk. We have, I know one particular patient, hypodiploidy and near triploidy, so high-risk cytogenetics. And those patients, she became MRD negative. She's now 5 years out, and we didn't transplant them. So we do want to know this information to come out from E1910, but it is showing, and even Wendy Stock at UC will say as well for 10403 that patients who are MRD negative have a very, very good outcome, and so don't need transplant.
And is that similar for Philadelphia positive patients in terms of those that achieve early with Blinn early?
Yeah, I mean,
TKI?
nobody is doing that I know in the group that I know. Nobody is doing transplant for MRD negative. I mean, we have very sensitive markers for MRD in these pH positive ALL, and nobody is doing transplant for those patients unless you can't get rid of their minimal residual disease. Then it would be advocated.
Thank you.
Thank you.
So I'd like to welcome now Dr. Noah Burt. He's our leukemia specialist as well, and he will update us with the new developments in acute myeloid leukemia.
Thank you,
Welcome,
Dr. Sanchez, for the introduction. Maybe I'll stand over here to switch things up and see how this works. Thank you, everybody, for sticking around for this last session. It's been a busy afternoon, and I appreciate you guys being here. Hope to share some interesting updates with you. The printed program says on endometrial and cervical cancer. So fortunately, we'll go real quick. At ASH, there were only 3 abstracts in the post-transplant CAR T setting, so it'll be real quick. Here's my disclosures. As you're all familiar, the molecular mutational profile for AML has been pretty well defined in the past 5 to 10 years with the advent of molecular testing. But what we've learned and realized is while we recognize AML as not being as heterogeneous as solid tumors, there are still a lot of different mutations that are present in patients with AML, and not all AMLs are treated the same. In particular, for this talk, for targeted therapies, we see the most common mutation in AML is in FLT3, for which we have targeted therapies. We know about IDH1 and 2 inhibitors, but there's still a lot of mutations for which we don't have specific targeted therapies, and we have to extrapolate how these might relate to prognosis for patients. Don't yet have necessarily predictive markers on how they might predict responses to targeted therapies for all of these different mutations. And in fact, we risk stratify patients now based on these molecular profiles. And some patients have markers that are more favorable risk, mutations, translocations in 1517 associated with acute promyelocytic leukemia and version 16 H21, better risk AML, CBP alpha. And then those we heard already about MLL fusions. Mutations involving chromatin epigenetic factors tend to have a worse prognosis, and of course in oncology TP53 associated with bad outcomes. Over the years, we've seen improvements in survival rates for patients with AML, and this is in part due to the recognition of the molecular biology and improvements in treatments, where we had pretty poor outcomes, less than 20% survival in young adult AML patients, and that's gradually ticked up over the recent decades now, with about a 50% overall survival rate for all comers in AML. Where we haven't seen the improvement, not advancing yet. There we go. Is in the elderly patients with AML aged 60 and older. We've only seen very small incremental improvements. And why is that? Are there different molecular features? Do we need better treatments for these patients? This is a timeline of the evolution of treatments for AML. The backbone for our induction chemotherapy has been around since the 1970s with 7+3. About a decade later, 2 decades later, we added idarubicin as an option to swap out for daunorubicin. 2000 brought approval of gemtuzumab ozogamicin, but that was taken off the market. 10 years later, still the backbone 7+3. Wasn't until 2017 that we saw some pretty significant updates with targeted therapies against FLT3 mutations, IDH2 inhibition with enasidenib, the combination CPX-351 for secondary AMLs or AMLs with MDS-related changes, and the reapproval of gemtuzumab for CD33 positive AMLs. Then excitingly in 2018, we had venetoclax arrive to the scene, IDH1 inhibition with ivosidenib and gilteritinib approved for relapse refractory FLT3 inhibition. And then since then, there haven't been a lot of major advancements in AML therapies. Some combinations have been brought to the market, but there's been a little bit of kind of quiet activity. We're waiting for the next movement going forward for clinical changing therapies. So that brings us to updates from ASH. We're going to do a tour through a few different topics. First, we'll tackle FLT3 mutated AMLs. Then we'll go to IDH1 and 2 positive AMLs. We'll review, we've heard already a little bit about KMT2A rearranged or MLL leukemias. And then we'll talk about combining targeted therapies for improving outcomes along the way. So FLT3 mutated AMLs, we had a first major update earlier in 2023 last year with the Quantum First study, where they looked at quizartinib in the frontline setting for induction therapy in FLT3 internal tandem duplicated AMLs. This was a phase 3 randomized double-blind placebo-controlled trial where they combined standard 7+3 induction with the oral inhibitor quizartinib at 40 milligrams daily dosing, or instead of quizartinib, placebo alone, and patients who had a good response up to the patient and clinician's discretion could move on to allogeneic stem cell transplant. And if they didn't go on for transplant, they received monotherapy quizartinib before, and if they went to transplant, they can continue it afterwards. And in that publication, we saw modest overall improvement survival in those patients who received quizartinib versus placebo, in addition to the standard 7+3 backbone. Of note, in that publication, they noted that there were rates of QTc prolongation that resulted in some cases in arrhythmias that led to a black box warning for quizartinib for QTc prolongation. There were increased rates of febrile neutropenia, hypokalemia, and pneumonia associated with quizartinib use, all things to be aware of when using this. ASH brought an update to the results from the Quantum First study in abstract 972, looking at treatment safety by treatment phase. Again, they were using quizartinib during induction, consolidation, and then as monotherapy, continuation therapy, as they called it. They noted that in general, the overall rates of treatment-related adverse events were about the same between the quizartinib and the placebo control group. However, specifically in the induction consolidation phase, the quizartinib patients had higher rates of GI upset, nausea, vomiting, diarrhea, along with pneumonia, sepsis, hypokalemia, febrile neutropenia, and as already reported, QTc prolongation. Of note, in these populations, they noted that the patients who went on to develop clinically significant arrhythmias were related to the hypokalemia. So they note that to be sure to monitor and replete electrolytes when patients are on quizartinib to help prevent that. And then in the maintenance phase where they're getting monotherapy with quizartinib, patients had increased associations of upper respiratory infections, GI upset, increased rates of myelosuppression and increases in ALT in these patients. So overall, pretty well tolerated for patients using quizartinib, a new FLT3 inhibitor in the induction, consolidation, and maintenance phases. Another follow-up abstract at ASH this year was abstract 832, where they looked at the ability of quizartinib to clear measurable residual disease and its association with improved overall survival. In the figure here, one on the left, it's showing the rates of MRD status, again, specifically for FLT3 internal tandem duplication in patients who initially received that composite complete remission at the end of induction, but they perhaps had positive MRD status after induction. They were waiting to clear the MRD, and they continued on quizartinib through consolidation, and they wanted to see what were the rates. And in fact, when you look at the number of patients who had no detectable MRD, there were increases in the cohort that, not surprisingly, received the targeted therapy quizartinib at 56% versus 41% for the placebo group. And this indeed translates into an improved overall survival probability, where those patients who achieved initially MRD positive at the end of induction, when they continued on quizartinib targeted therapy, they had improved overall survival with the targeted therapy, suggesting, as we heard from the ALL talk, MRD status does matter, and perhaps having a targeted therapy can help reduce the overall survival rates by deepening that response. Interesting, abstract 158 was a phase 1/2 study using combination quizartinib, venetoclax, and decitabine triple combination in patients with FLT3 mutated AML, as opposed to the Quantum first study that we just heard about, is pairing quizartinib with intense 7+3 induction. Patients who were unfit for intense induction therapy are often left out of the option for a targeted therapy. So this is asking, can we use in the frontline setting quizartinib for patients who will receive less intense induction therapy, and also patients who have previously received treatment and have relapsed, they're FLT3 positive, but they've relapsed, looking at two different cohorts and saying, can we combine this novel combination of venetoclax, hypomethylating agent, and quizartinib and look at the response rates? They had 10 patients in the newly diagnosed AML group and 40 patients in the relapsed refractory AML group. Of note, in the frontline group, while it's a small group, 100% received a composite complete remission, meaning no morphologic evidence of disease, and if anything, just MRD status, molecular presence. And by day 14, they had very early response. They had less than 5% blast, really the best response rate you can imagine for patients who are otherwise unfit to receive intense induction. Looking at the 30 and 60-day mortality rates of these patients, again, they were unfit. They had 0 mortalities in the first 60 days in this small cohort, and 40% of those patients were able to be bridged to a transplant despite not receiving intense induction upfront. And while the rates of the complete remission were not as high in the relapsed refractory group, 68% is still incredible, considering patients may have received as many as 4 lines of previous treatment. So to see that you're able to have additional treatments is quite significant, either in the front line or in subsequent settings. So there's an area where you can add quizartinib potentially for patients in the future. We'll switch over now to IDH1 and 2 mutated AMLs. As you're familiar, about 20% of cases of AML have either an IDH1 or IDH2 mutation. A little bit higher rates, 25%, in older adults. More common are IDH2 mutations than IDH1. The mutation is associated with increased levels of 2-hydroxyglutarate, which blocks differentiation so that these cells are immature and you get increased blasts in the bone marrow and eventually circulation. For the NCCN guidelines that are currently available, patients who either have IDH1 or 2 mutations are not fit for induction. You can start with a targeted therapy up front, and we know you can also use it in the relapsed refractory setting. Usually you don't use IDH1 or 2 inhibitors alone as monotherapy. The preferred treatment recommendations are azacitidine with venetoclax, or a targeted approach using ivosidenib with azacitidine. For IDH2, a category 2B recommendation is using enasidenib with azacitidine currently. But you have two category 1 recommendations that are perhaps conflicting. As a practitioner, do you go with the targeted therapy IDH1 inhibitor first, or do you save that later? So there was an abstract by Eitan Stein's group, abstract 1534, the iData study, looking at just that. How do we sequence therapies and what are the results? So patients 18 and older were randomized if they had an IDH1 or 2 inhibitor, 1-to-1 to either receive inhibition, a targeted approach with azacitidine upfront versus the combination of venetoclax and azacitidine. And once they achieved treatment failure, they could switch over to the other treatment. The study was early in enrollment, only 5 patients at the start of the abstract submission. The update from ASH was that preliminarily, it seems that there are increased benefits using the IDH inhibitor upfront. You get more robust response rates. However, instead, if you've used the venetoclax first, you're not going to have as durable responses when you save the targeted therapy later. Interesting, there's a new IDH1 inhibitor that was presented in abstract 2888, olutasidenib. It's currently FDA approved specifically for relapsed refractory AML with IDH1 inhibition. And this was a study that looked at relapse after either hematopoietic stem cell transplant, after prior IDH1 inhibition, or after prior venetoclax use. They did a post hoc analysis from the initial study, an original phase 1/2 open label multi-institutional study that includes 60 patients, and looked at patients who had received the prior treatments, transplant, ivosidenib, or venetoclax. And they reported composite complete remissions. Again, those that had complete remissions or complete remissions with incomplete hematologic recovery. They observed 29% of patients had complete composite remissions following transplant, 22% following ivosidenib, another IDH1 inhibitor, and 45% response rates even after receiving venetoclax. There were mixed responses observed for patients who received either the IDH1 inhibitor olutasidenib as monotherapy, or some practitioners combined it with azacitidine. So this is a very promising, suggesting that even if you've already inhibited targeted IDH1, you have a second agent that can be available in the relapsed refractory setting, or if people have been heavily pretreated, you can use this IDH1 inhibitor. And then to build on that, abstract 968 is a phase 1b/2 study of the combination oral decitabine and cedazuridine in combination with venetoclax, and then seeing, can you add an IDH1 inhibitor? This looked at about 50 patients with either IDH1 or 2 mutations in either the newly diagnosed AML setting, or again, patients who had relapsed refractory AML. Interesting, those who had IDH2 mutations had 100% composite complete remission rates. IDH1, exceptionally 90% rates, complete response rates, for a total of 96%. In the relapse refractory setting, not surprising, these are patients that had multiple lines of prior treatment, but still quite significant, about 46% complete response rates for this combination oral regimen. Looking at the prior therapies, where do we see the most benefit and perhaps the least? Those who had previously been treated with hypomethylating agent and venetoclax showed the least response to the combination, adding the IDH inhibition afterwards. Those that had the greatest were those that had never received venetoclax beforehand. So if you're trying to get the targeted therapy, perhaps get it in before you're exposing to venetoclax or in combination. And what's particularly interesting, those of you who are familiar with this combination, venetoclax, the oral decitabine, cedazuridine, it's an all oral combination. Are we talking about moving intense induction in the inpatient setting requiring 4-week hospitalizations, lots of support, complications? Is this something that one day maybe a community practitioner could dispense from their clinic, monitor their counts in an outpatient setting, and have effective response rates of up to 90 or 100%? This is really incredible to think about how we might be able to support these kind of patients with all oral combinations using targeted therapies as the backbone instead of 7+3. And now we'll switch to KMT2A rearranged AML, or what was previously defined as mixed lineage leukemia. It got this name, mixed lineage leukemia, because these are rearrangements that are found in both the lymphoid and the myeloid lineages. Depending on the fusion partner in which pathways are perturbed, it could shift stem cells to differentiate into the lymphoid, causing acute lymphoid leukemia or acute myeloid leukemia. These result from chromosomal rearrangements involving the MLL or KMT2A gene on chromosome 11. And these translocations can have with many different other chromosomes and gene partners, relating to an oncogenic fusion protein that, as Dr. Quigley mentioned, causes a blockage in differentiation in the development of acute leukemia. And as we talked about before, MLL fusions in particular have a dismal prognosis, with less than a third of the patients surviving after they've gone through intense induction, supportive care, and perhaps a stem cell transplant. The outcomes have been dismal since MLL was first defined, and we have no targeted therapies, despite knowing that there is one specific rearrangement that drives this aggressive adverse disease. This is a schematic of the large MLL protein. It's a multi-domain protein that has two DNA binding domains, AT hooks, CXXC domain. You have the menin binding site at the N terminus that binds also to leg F. You have several protein interaction domains. And at the C terminus, you have the enzymatic activity with the set domain that provides the lysine methyltransferase activity. That's where you get the name from. K for the biochemical letter that represents lysine methyltransferase, and then 2A, the class of the histomethyltransferase that places active chromatin marks to turn genes on to say, hey, stay as a stem cell, stay as an undifferentiated cell. And normally, MLL shuts down, as cells are supposed to differentiate, shuts down those gene pathways so you can go through normal sequential hematopoietic development. However, when you have one of these chromosomal translocations, it results in a fusion protein where you have the N terminus fused to more than 70 different C-terminal fusion partners. You always necessarily retain the N terminus with these DNA binding domains that interact with the menin protein of interest. And when this happens, you recruit the super elongation complex or transcriptional activators to turn these genes on, keep them revved up so you prevent normal hematopoietic differentiation. And the thought process is, can you target this N terminus, in this case, the critical menin interaction, to disrupt gene transcription that's driving leukemic transformation? So as Dr. Quigley alluded to in the ALL talk as well, because again, we're talking about mixed lineage leukemia. This is involved in both ALLs and AMLs. There's a late-breaking abstract of revumenib monotherapy in patients with relapsed refractory KMT2A acute leukemia. This could be acute myeloid or acute lymphoid leukemia. And they reported the top-line efficacy and safety results from the Augment 101 phase 2 study. They looked at both adult and pediatric patients with both KMT2A rearrangements and NPM1 mutations. Interestingly, a lot of NPM1 mutations are co-mutated with MLL. And as we talked about, some of the same pathways, gene sets are upregulated in NPM1, thinking that perhaps we can target those by targeting menin. They used a dose escalation study where different arms were allowed to be exposed to CYP3A4 inhibitors, and trying to identify the recommended phase 2 dosing, characterize safety, tolerability, and an exploratory objective was looking at the actual anti-leukemic activity in the MLL or NPM1 mutated patients. There were 94 patients that were enrolled, and they received a median of 2 prior lines of therapy. Again, this is in the relapse refractory setting. Ages ranged from 1.3 to 75 years with a median follow-up of 6.1 months. The most common adverse events were nausea, differentiation syndrome, and QTc prolongation. On the left, you can see the swimmer's plot looking at the duration of treatment. In blue, you have the KMT2A rearranged AML patients. In orange, you have the NPM1 mutated. You see the overall median duration of response for the combined overall data. The abstract reported an updated interim analysis where about a quarter of the patients, 22.8% of the patients, had a composite complete response. And of those that had a complete response, 70% were able to achieve MRD negativity, which is huge. When you talk about previously treated at least 2 lines of prior treatment, on average, 70% were able to clear the MRD positivity and likely get these patients to the transplant that they need to get them the durable remission. Another study, Abstract 57, was a first in human phase 1 study of the J&J menin inhibitor. They enrolled about 50 patients so far at the time of this abstract, and you have a waterfall plot showing the best response in bone marrow burden. About a third of the patients had a 50% reduction in the bone marrow leukemic burden. Again, these are relapsed refractory settings, so patients who have been refractory have been treated before. Having a third of the patients have a response in that setting is great. And is certainly promising. And here's a swimmer's plot showing that patients still remain on this phase 1 study. This was a dose escalation. They've gone through multiple levels of dose escalation. No recommended phase 2 dosing yet has been achieved. The major dose limiting toxicity is differentiation syndrome, just like what is seen with revumenib. So again, promising. I think there's work to continue to be made with menin inhibition. And in fact, there are several different menin inhibitors under development. Revumenib is the one that's the furthest along in phase 2. Ziftomenib is right behind it. The J&J one that I just explained or presented is in the early stages, a couple others under development. So this really is recognized as a hot target that's going to be really exciting, and I think practice changing for a specific target that's been really had a poor outcome for decades. And now we have a target that seems to be effective. So we've talked about FLT3 mutated AML, focusing on quizartinib in the frontline setting for induction in combination with intense induction, helping patients achieve MRD negativity. We've talked about it in combination with hypomethylator agent and venetoclax, showing improved response in the relapsed refractory setting. We talked about IDH1 and 2 inhibitors for AML and promise for the relapse refractory setting, having a second generation IDH1 inhibitor that can be available for patients who have relapsed or been refractory to ivosidenib. We've talked about the novel oral combination that can be used with the IDH inhibitors upfront. That will be exciting to see how that manifests in the years ahead. We talked about menin inhibition for KMT2A rearranged AML. And in that, we talked about different combinations of therapy. What will be exciting for the menin inhibitors, these are all in monotherapy testing right now in the relapsed refractory setting. But as we've talked about for FLT3 and IDH1 and 2 mutated AMLs, is the real benefit going to be moving these upfront early and seeing what kind of combinations with intense induction or less intense induction might give long-term benefits for these patients. So overall, the goals of targeted treatment in AML are going to help be to induce a response, induce a remission for these patients, deepen that response by getting to MRD negativity, and then maintain those durable remissions after consolidation, before and after transplant, with the ultimate target for AML therapy being to achieve that cure. With that, I thank you for your attention. And happy to take any questions you have.
Tip your hand that you might be a lysine methyltransferase inhibitor expert. So in keeping with that, just a few questions on that. First, is KMT2A specific to the hematopoietic compartment?
It is not. So it's one of the critical enzymes that regulates embryonic development. It continues to be active and critical during hematopoietic development, but during embryogenesis in particular, it's active in multiple different compartments.
So I think I've seen it show up as a target in other cancers. This is my question. So it sounds like it might be.
Yeah.
Okay. And then the menin inhibition pathway, that should not necessarily be heme compartment specific, but could be broadened.
Correct. And it's a critical interaction that is conserved through homologs in different species, that interaction between menin, LEGF, and MLL or KMT2A.
And then last question, are the inhibitors specific to KMT2A or will they hit other lysine methyltransferases?
They would hit all of the MLL class because you have the menin binding domain that interacts. So it would be interesting to understand how that might impact other disease types. The other homologs of MLL, so KMT2, B, C, and D, a few of them are implicated. MLL2 or KMT2B is implicated in small rare cases of breast cancer.
I'm getting dorked out here. I apologize, everyone. And so I'm sort of assuming people have done chip type studies, et cetera. And
Yeah.
okay.
Yeah, lots of chip.
Questions, anybody? So I have one question. So
Yeah.
now for FLT3 positive AML, which ones of the three inhibitors would you choose now that we have this data that quizartinib is not as toxic as we thought about? There's no randomized comparison, but what are your thoughts about that? And how are you going to change your practice?
That's a great question, Dr. Sanchez. He's alluding to, so the first in class was midostaurin used for induction beginning on day 8 of therapy and continuing the role for maintenance therapy pre and post-transplant. Gilteritinib is in the relapsed refractory setting, but there are some interesting studies that should be coming out in the next year. Hopefully next ASH, if we do an update, we'll include that in saying, can that be used in during induction? And now we have quizartinib to compete with midostaurin as an induction combination therapy. There aren't going to be any head-to-head studies, so it's going to be hard to decide. I think more where quizartinib may have a head start is in these combination therapies with the other oral targeted therapies. I could think that could be really exciting, especially if they're getting into that space and deciding how can we use it in a unique way that midostaurin currently isn't available. Personally, I'm most familiar with midostaurin at this time, how to manage it, monitor the side effects. I wouldn't be opposed to learning about quizartinib personally with patients, knowing that we have to watch for QTc prolongation, monitor the electrolytes, support the GI upset. I think we'll just need some longer term data to find out ease of use and if there are any improved benefits that we're seeing that aren't yet reported.
Thank
Great
you.
question. All right. Thank you, everybody.
Okay, so everybody, before they leave, you have to sign in the URL that has been posted in the chat. So everything will be sent to your emails, the one that you when you sign it to the session. So those are the new housekeeping issues. Yeah, and remember to validate your parking downstairs.
Finally, it's been hard to get here. That's